We're making a big deal about accountable care organizations and bundled payments as a way to promote change. And there are some real positive aspects of doing things in a coordinated way, having teams. As I said, it was just wonderful to follow Dr. Hightower, because what he was talking about is really what we're all about. And of course, when you understand it, what it does in a positive sense, it puts you back in control. So we got three choices. Nobody's in control, or I'm in control, or you're in control. Which would you prefer? Pick three. Thank you. That's what when you go to global budgets, as I said, assuming that we go at some point to somebody's in control, it's either going to be some outside regulator that says you can't do that, you can't do that, you can't do that, you can't do that. As I said, you go to Canada, for example. The way the Canadian system basically works is they give every part of the system a budget. And everybody complains about the budget, and the government says, I'll see you next year. Do whatever you want, but this is all the money you got to spend. They don't second guess their doctors. They don't regulate what they do. They just don't give them the money. What we do is you say, doctor, you can spend anything you want, but I don't trust you a bit. I'm going to second guess everything you do. I'm going to look over your shoulder. You can't do those x-rays, the MRIs and stuff like that. You can't do that. So what you do with global budgets, you basically give you a budget. And we say, do the best you can and figure out how to spend it. But you're in charge. Now, you may not want to be in charge, but that's what it's all about, whether it's through the accountable care, the affordable care, the accountable care system, the global budgets, or through bundled payments. And it does. It rewards less fragmented care if you figure out what works and what doesn't and use it. It permits care providers to pay for service. And this is an important area. It's a tricky area. We know now, you know, that there are certain expenditures for people that are traditionally not in the healthcare line that really help them. I see Dr. Altman in the front. She and I are trying to figure out a way to create a set of criteria for what we call patient-centered medical homes. And we're trying to figure out, she's trying to figure out, and I'm trying to figure out what she's saying. And that's the way that works. What we're trying to figure out is things that work and really make a difference, as opposed to things that just sound good. So that and some of these things, these events, aren't traditionally in there. Like last week I was with Governor Kitzhaber from Oregon, and he talks about the idea of this older woman who kept coming back and forth to he's an emergency room physician, into the emergency. And what they found out is that she lived in a really, the fifth floor. Sun was there, no air conditioning and stuff like that, and she got really hot and stuff like that, and she got sick and then went. And they actually now, they have a new coordinated care group, and they actually provided an air conditioner for her. Now, we never should include air conditioning in, a CPT code or whatever it is, maybe in the new version of 10 there's air conditioning, but I don't know. I know there's flat screen TV. So the point here is, but if you have a budget and it might pay for you to spend it on an air conditioner. So that's the value of all this stuff. What we're finding is that the real key to financial differences is not in the acute care side. Big shock, it's on the post-acute. Now, many of you, particularly those of you who work in hospitals, you think you're finished. You've done your operation. The patient seems like they're okay. They need rehab and stuff like that. You give them a sheet of paper and they leave, and you go to worry about your next patient. We actually spend, if you can believe it, more money on the post-acute side than we do on the acute care side for a lot of very complicated illnesses, and henceforth you are not going to be out of the game when that patient, not you necessarily, your hospital, your clinic, your group. So we are moving forward. I just want to show you the numbers. Major joint, heart failure, renal failure. We spend the blue, this is what Medicare spends for a group of patients. Look how much we spend after the hospital. Look at these numbers. This came as a gigantic shock to everybody that's looked at them. There's a new IOM study coming out talks about major differences in geographic area and spending. You know what the single biggest reason why? It's the amount of money they spend in post-acute care. We are going to have to figure out a way to integrate post-acute care into the acute care side, and whether you're going to be in charge of both, or they're going to be in charge of you, or some combination of the two, we got to figure it out. So we're going to be active participants. States need to be involved in this thing. Now, I'm not going to spend much time on Massachusetts. I probably have used up all my time, but I just want to say this. As I said before, we are not a regulatory agency with the commission. And we're working with the state and with private insurers in terms of restructuring the payment system. So, you know, our insurers are doing things. Yes, they're going to limited networks here and there to make people concerned about the high costs. Because one of the big reasons why we spend more is not on utilization. What we are learning is America is not overutilizing. The big difference between us and other countries are the prices. It's the prices of everything, the drugs, the devices, the malpractice, the cost of equipment, the cost of the buildings. So we're trying to deal with that. And I am tremendously proud to be part of Massachusetts. I think what we're doing and trying to do is we're so far ahead of the rest of the country, both on how you practice medicine and our organizations. We're the leaders, and we need to continue to be the leaders. So we are trying to do that. And as I said, the commission, you know, this legislation has a lot of pieces to it, 224. But our group, the Health Policy Commission, as I said, is responsible for overseeing this, to encourage community hospitals to do more, to pay for reform, to work with our Center for Health Information and Analysis. And to be required, yes, we're assessing market competition, consolidation, whether it's really good for the patients or not, whether it's good for the system. We are much more involved in grant programs for community hospitals. As I said, we're establishing certificate programs for patient-centered medical homes, and we are working with others, the payers and the providers, to put transparency. And our goal is to reach this, have the growth in our spending be consistent with the growth in the state GDP. Not cut growth, but have it in a line. So we're not a regulatory body, so the question is, what are we? So my view of us, we're like your mother. Our job is to make sure you eat your vegetables. Because if you don't, what looms ahead? So the question I ask again, what would you rather have? And with that, I'll stop. Thank you very much.